Good morning, lovely people. It's very, very early here in San Francisco, and it's also cold, but we're braving the weather nonetheless, in large part because of the warmth of this space. And today I'm very excited to co-discussing with Mariana, who honestly needs no introduction. She's been a CP Solvers team member approaching a year now, and she's actually she does a really really good job of doing incredible things behind the scenes, which is part of why we're bringing her to the forefront of the scenes today. She's basically revolutionized what CP Solvers does in social media, and everything that you see on Instagram that's new over the last years essentially has her fingerprint on it. The other thing that she has famously contributed to with little to no overt recognition is a new initiative that was launched and is in its early phases, but she had the brilliant idea of creating an electronic book with cases and schemas that was also very visually appealing. But I think what we recognize Mariana for is her deep love for medicine and her deep love for building community, which I think you all seen what she does, and I'm very, very excited to share the stage with her today. I'll hand the mic to Mariana to say hi, and then we can introduce our savior case presenter.
Hello, everyone. Very happy to be here today. Thank you, Rabih, for these kind words, and thank you, everyone. Um, I'm very excited to be discussing a case today. For those who don't know me, I am a medical graduate from Brazil, and I'm studying for my steps. Hopefully, I'll be applying for internal medicine residency soon. And uh, yeah, let's do it.
Amazing, amazing, Mariana. That sounds wonderful. Sorry, I got a little distracted because Alec, I think I just saw Han join. And yeah, let me see if she is available. Han, good morning, or probably more accurately, good evening. I'm not sure if you can hear me. I don't think I see your video on. Um,
Um,
Hi Han, how are you?
I'm fine. Sorry, my internet connection is quite unstable.
Oh, no problem at all. No problem at all. Do you think that you're still able to present today, or is the connection fine for now?
Yes, I can present the case today.
Oh, well, wonderful. Han, I'm lucky enough to be joined by Mariana, who will be co-discussing the case, and you joined at the time that we were just about to pass the mic to the case presenter. So I will do that now and pass the mic to you to just introduce yourself and tell us a little bit about you, and then we'll
Yeah,
go ahead and jump into the case.
yes. I am a medical doctor from Vietnam. Now I am working in infectious the department in the hospital and happy 10 in ICU training. And I'm really glad to be here today to present the case.
Yeah, I think you presented many interesting case, including some very interesting infectious diseases. So we'll see what you have to teach us today. Sohail is scribing and Julia is doing the teaching points, and together we'll have a ton of fun. So we're ready whenever you are.
Yeah. I start with the chief complaint with the fever. Yeah.
Oh wow, that's
Uh,
all you're gonna give us, huh? Fever, or are you planning to give us a little more?
yeah. I can give more information. This is a 50 years old male who presented to a provincial hospital with a fever and severe headache. Uh, After 30 minutes in the provincial hospital, he became unconscious. The physical examination was revealed that his eyes were closed and he didn't respond to questions from his family members, and uh, he didn't do any demand from a physician. Uh, then the patient was immediately transferred into a tuberculosis hospital in the city. On arrival, he became agitated, yelling, and lost the vision. In the tuberculosis hospital, he was ordered a lumbar puncture, he received a dose and transferred into an infectious hospital. This is end of eloquent one.
Wow, that's a very, very dramatic start to this case. Mariana, I think that there's a lot of aspects to this case. There's fever, there's headache, and there's essentially advanced encephalopathy. I'm curious, where do you think your anchoring point is? Are you more thinking about the fever, the headache, and the encephalopathy, or what is grabbing your attention the most?
So I think the encephalopathy would be the most important point right now. And I would like to know for how long this fever has been going on because um, it seems like something hyperacute, but if the fever started like a long time ago, it can change the way that we're going to tackle this. So I would be interested in knowing that. And but the severe headache and the encephalopathy for me are the most important points right now.
I completely agree with that. I think that whenever you have fever and a headache, it's tempting to think that that means that there is inflammation inside the brain. But as we've seen many times and probably experienced ourselves, most of the time it's that the head hurts from an extracranial inflammation like COVID or flu. But as soon as you invoke the idea that there is encephalopathy, it becomes much more localizing to the brain itself. And so, if we were to assume the fever is acute, which would prioritize infection, where in your mind do you think somebody can be inflamed or infected in their brain? So, if we're thinking, okay, you know what, this is a cranial infection, where might you think that the problem might be?
So it can be in the parenchyma and also in the meningeal
Yeah.
space.
Yeah, excellent. I think those are the two leading causes for sure. And where, if you were to prioritize parenchyma versus meninges, where do you think you would lead with one of those two?
Because of the loss of consciousness, I would think it is a problem in the parenchyma.
Yeah, I think exactly right. It gets a little bit tricky, um, because if there's a loss of consciousness, you must invoke some sort of brain dysfunction. The question then is, Mariana, where does loss of consciousness localize in the brain? So where do you think that that tells you the problem is?
Um, I would think more in the reticular system and also in the pons, thinking about loss of consciousness.
Yes. The, the most common cause of a focal lesion causing loss of consciousness is in the brainstem. Um, the most common, however, is a diffuse cortical problem. So either you have a problem in the brainstem or all your cortex is down. And so you know that this person has a loss of consciousness. And so you're like, is it a focal lesion? And does this person have brainstem encephalitis or what's called rhombencephalitis? Without obvious cranial nerve deficits or obvious limb weakness, that localization is put into question, and you start to wonder whether the patient has a diffuse cortical problem. And so, this is the importance of the distinction between encephalitis and meningitis. Strictly speaking, meningitis should be just inflammation of the meninges without extension into the brain parenchyma. So when we say parenchyma, I think it's really key to try to say, is it focal or diffuse? And I think based on the lack of overt limb weakness. The localization that I'm most curious about is a diffuse parenchymal process. And the most common localization of a diffuse parenchymal process in the realm of infection is a meningoencephalitis. Both the meninges and the brain are involved. And so here, I think that if you go back to the original breakdown of inflammation in the brain, is it parenchyma or a meninges? The one other rare localization is vascular in the vessels. And the most important thing to consider there is multifocal embolic phenomenon, such as endocarditis, causing vascular inflammation. That's the least common. When the parenchymal involvement is focal, it's much more likely that you're dealing with a focal brain lesion. But when the parenchymal involvement here in the form of loss of consciousness is diffuse, then the origin of the inflammation is likely meningeal with subsequent extension into the diffuse cortical space. So I would say fever plus brain equals parenchyma, meninges, and then vascular. If you find focality on your exam, you're much more likely to have started in the parenchyma. If you don't find focality on your exam, it's much more likely that the issue originated in the meninges and then bled over to cause an encephalitis. And I think you're seeing that play out here in Han's case by her starting to tell us that they immediately got a lumbar puncture to look for a primary meningeal process that probably subsequently got into the brain. And in this space, we don't really know how long the fever is and whatnot. But reflexively, what would you say are the most common infectious organisms that would be crossing your mind with such little information? What would you be thinking about in terms of organisms?
Regarding, if I think about parenchyma and meningitis, I would think about meningococcus and pneumococcal. And if I think about virus causing that, I would think about herpes virus. And we can also have a septic meningitis with enterococcus, with enterovirus, sorry.
Excellent. I think that's exactly right. Viral causes would be herpes and enterovirus. Bacterial causes would be strep pneumo and Neisseria meningitidis. And in many parts of the world, because of how common they are, TB and Cryptococcus have to be entertained early on. And you can see that in Vietnam, where TB is endemic, that patient was transferred to a TB hospital just based on the sheer prevalence. Though in the United States, we often don't have to think about those two organisms unless they're unique circumstances. And so I think the next stage, Mariana, in these kinds of cases is to pay attention to whether the person just has a brain problem or has a brain problem with a systemic disease. So if a patient has herpes encephalitis, they shouldn't have any systemic disease. It's just the brain. But if somebody has strep pneumomeningitis, they often have systemic inflammation. And the same is true for TB or crypto, though they often live in the world between. So strep pneumo and Neisseria meningitis, the patient will have systemic disease with brain manifestation. On the opposite side, patients with viral encephalitis almost have no other manifestations. Patients with TB and crypto can lie in between, and we've seen many cases of just crypto meningitis alone and TB meningitis alone, though if we see something in the lungs for TB and crypto, we wouldn't be surprised. So right now, I think our important step is to work up the neuro, but keep our eyes open for non-neuro clues that can help us pick between these three categories of pure neurovirus, systemic, prominent systemic bacteria, or in between TB and crypto. But something that you said earlier will be even more informative, which is what is the time course of this syndrome? Because both viral and bacterial are often acute, and if we hear this is more subacute, we might prioritize that middle category. Any questions come up for you or thoughts that you wanted to add before we pass the mic back to Han?
I think I'm right there with you. And the most challenging for me is to organize the thought. So I think we were able to do that.
Oh, yeah, Mariana, it takes about 25 years to doing this over and over again to organize the thoughts, but we're on that journey together. All right, Han, tell us more, please.
Yes. I continue with my other question. Before the onset of the symptom 2 days ago, the patient had drunk a lot of alcohol and he stopped usage a day before he being admitted to the provincial hospital. He has no chest pain, short of breath, night sweat, cough, nausea, or vomiting. Review of the symptoms: he has fever, headache, loss of vision, deafness, no weight loss, no night sweat, no cough, and no chest pain. In terms of her past medical history, he had done osteogenesis in the left thigh 2 years ago due to a traffic accident. He had no blood transfusion or TB or liver disease. He wasn't on any medication. Family history: he lived with his wife and 2 children in the south of Vietnam. None of them have TB or liver disease. Social history: he was a retired rice farmer. His job wasn't related to pig or pork. He drank a lot of alcohol, about 3 or 4 times per week. Unknown amount of alcohol. He didn't use any substance. Physical examination revealed that he had a fever with a temperature of 38.5 Celsius degree. The heart rate is 100. The blood pressure is 150/99. The respiratory 20, and the oxygen saturation is 98%. He generation he awake, but no response to any question of physician, and he quiet, agitating. About his deafness and vision loss, he has no ulcer. The CV and the pulmonary examination, all of them are normal. Abdominal examination, there's no lesion or no distension or no tenderness. About the neurology, we evaluate him with the Glasgow 12, bilateral dilate pupil, neck stiffness, Bruniski side negative and Konish side negative. His extremities and skin, no rash, no lesion, or no visible wounds in his hand and feet. This is end of our question.
Thank you so much, Han. This is very, very helpful. Mariana, I'm curious, what we have that initial map. What progress did you make with the history and the exam?
So something that we didn't mention it was that he was agitated and lost his vision. And with this history of alcohol use, I would like to know for how long, or if this patient has any type of chronic alcohol use, because if so, and the patient stopped to drink a day before, we could blame the alcohol use on the agitation, and we would need to know what is noise and what is signal, because the agitation could be because of the alcohol withdrawal, and it could be not part of the syndrome, or it could be part of the syndrome. So I think this is something important to distinguish before we go on. And let me see what else. So it doesn't seem like this patient has a systemic disease. So I wouldn't rule out, but I would not be considering as much as we were before, like pneumococcal and meningococcal. So I would be not very concerned about that right now. And let me see. I think that's what I'm thinking right now.
Yeah, no, I agree with you. I think that there's really a lack of systemic signature to this disease so far, but I think that the labs can be even more illuminating. I think maybe I can just clarify with Han. Han, does he also have hearing loss or is it just vision loss?
As he has both vision loss and hearing loss.
I see. And both of these hearing loss and vision loss are new, is that right?
Yes, that is right. Yeah.
Thank
All
you.
are acute symptom.
And both are acute symptoms. Okay, that's very helpful. Yeah, Mariana, I agree with you. I think that this seems to be a very hectic, devastating neurologic disease without any systemic um, fingerprint. And I think it's very interesting to see that he has both hearing loss and vision loss. And I say that because in the context of his brain being involved, we might invoke all this being central nervous system disease. But I think it's important to invoke remember that the optic nerve has a very distinct pathway than the cranial nerves. The optic nerve is a central nervous system process, hence its vulnerability to a demyelinating disease like MS, and the cranial nerves are in the peripheral nervous system. And so here, it's a little bit tricky to try to connect both of them. And so I think if we just go through a quick checklist of how somebody may have vision loss and confusion, there's not many things that I can think of. The most reflexive thing in a patient who's hypertensive is to think about PRES or posterior reversible encephalopathy syndrome. The other thing that can happen is sometimes you can have pituitary hemorrhage or pituitary apoplexy that causes encephalopathy and compresses on the optic chiasm. And then, of course, you can get optic nerve issues from other substances that can cause encephalopathy separately. And I think the most morbid one that I can think of is in a patient, especially who has alcohol use, is methanol intoxication, which can cause some brain hemorrhages and vision loss. But it's hard to honestly to make progress on how somebody could have vision loss and deafness at the same time, except to wonder, does this patient have really aggressive meningitis, so much so that their meninges are inflamed and causing compression and dysfunction of the adjacent exiting nerves. I know that I know that as a complication of meningitis to get deafness and hearing loss. I just don't know if you can inflame the optic nerve in the same way that the other cranial nerves are inflamed because the pathway is so different. So I would have to look up, it's a knowledge gap for me, whether you can become blind from meningitis. I think we've actually had cases of hearing loss from meningitis. So that's a knowledge gap for me. I'm curious, if this patient were in front of you, what do you think would be helpful next steps?
A lumbar puncture would be my first choice. Actually, I think I would start with a brain CT first and then lumbar puncture.
Yeah, and can you explain why you installed the brain CT before? What do you think? What were you thinking then?
I think we have to rule out parenchymal edema before to do the lumbar puncture.
I completely agree with you. I think that I'm just going to show people a schema. When you're thinking of meningitis, um, and you really have to be very systematic about how to think about it. And the first thing is always to do your systemic evaluation, which we're doing. The yield of blood cultures for bacterial meningitis is about 50%. It's not low. And then always, if you're worried about bacterial meningitis, you should give patients empiric treatment of vancomycin, ceftriaxone, plus minus ampicillin, plus minus acyclovir, and we can talk about the details later. And consider steroids. You should get a CT scan if you have a focal problem, and here the vision loss and hearing loss are focal problems, and then get an LP. The idea being that if you have a focal lesion, you may increase the risk of brain herniation if you do a lumbar puncture. So I think, Mariana, what I was able to gather was the patient's alcohol use is chronic and significant. And so the question here is, do you give acyclovir? And I think you might. There's no harm in it. The question is, do you give ampicillin? And Listeria, the organism that we use ampicillin for, is one of the infections that can happen very aggressively in pregnant patients, most classically, and patients who are on TNF blockers, but also in patients with alcohol use. So I think this patient, because of his alcohol use, would cross my threshold to give him ampicillin since he's this sick. The age cutoff is 55, so he wouldn't meet for age, but I think for alcohol use, it's probably a good idea to give him Listeria coverage in addition to pneumococcus and meningococcus. But yeah, I think we're going to need a lot more information, but this patient's probably too sick for us to wait, and we should probably empirically treat him since he's so sick. And we'll try to figure out why he's confused, why he's febrile, why he's having vision and hearing loss. Han, tell us more, please.
My third request is a lab finding with the white blood cell is 10.6, neutrophils is 8.1, which is slightly elevated. The lymphocyte is 0.79. The eosinophil is in the 0.04. The percentage of eosinophil is 0.4%. The hemoglobin, he has a 12.9. The hematocrit is 43.2%. The blood cells is in the normal range with 180. The glass chemistry reveal the sodium and the potassium in the normal range. The BUN is 26.8 in the milligram per liter. The creatinine is normal. The glucose is 4.44. The bilirubin is 23.1, and in the direct bilirubin is 13.8. The AST and the ALT is all in the normal range. The 3GT is a normal range. We have imaging with the jet X-ray is normal. The brain, the MRI is thickening in two rows, and it had a blue level in the lateral ventricle. This is end of my report.
Oh, thank you so much, Han. Can I just ask one question? What is the normal level for bilirubin in your lab? Is this elevated or is it normal?
The bilirubin is normal.
Okay. So, Mariana, you were asking the question, is there a systemic fingerprint to this disease? What do you think?
So with this bilirubin, I was already thinking about acute liver failure, but now that is normal.
Yeah.
So I don't think there is a systemic
Yeah.
here.
Mhm. Yeah, 100%. I don't think there's a systemic fingerprint of this disease either, which makes it very, very interesting. So, yeah, if we were to go back to that original framework, you mentioned earlier that you really wanted to know what the time course is, and the time course is acute. And so now we're saying, could this be a viral process? I think it would be very rare for TB and crypto to present acutely. And the question for us is, does the lack of a systemic fingerprint completely eliminate the scary bacterial causes? And if not, does it help prioritize the order or the likelihood of the three most common, strep pneumo, Neisseria meningitis, and listeria? But let's answer that question after we analyze the MRI, which is the one data point that we had um, that got us going. So how are you interpreting the MRI findings?
Well, with the thickening dural,
Yeah.
should I think in a meningeal process?
Yeah. Yeah, exactly right. Yeah, it's very tricky to think about as an incoming internal medicine doctor to interpret a brain MRI, but that's exactly right. Whenever you have thickening of the meninges, there's really three possibilities. There's inflammation or meningitis, which is divided into leptomeningeal inflammation versus pachymeningeal inflammation, which is a conversation we don't need to focus on today. The other is that there is CSF pressure changes, and the dura is thickened not because of inflammation, but because of edema, especially in CSF hypotension or low CSF pressure. The dura can also be thickened in the context of edema, not from CSF hypotension, but also from a dural venous sinus thrombosis, which would probably have been noticed on the MRI. The lack of other MRI changes also makes CSF hypotension less likely. So if we talk about just regular old edema, CSF hypotension, and dural venous sinus thrombosis, inflammation, which we're thinking about really hard here, and the last one is irritation by a lumbar puncture. So it's always a good idea to try to do, if you need to, a lumbar puncture after the MRI, because the lumbar puncture itself, after puncturing the meninges, can cause them to light up. In a case like this where the lumbar puncture is so urgent, it's common that the MRI is done afterwards if it's needed. So here I think we have to think, was the dural thickening there before the LP was done? Or was it not? And we don't know. The only way we'll be able to know is to look at those lumbar puncture results done at the other hospital. There's another finding here, which is their fluid level in the lateral ventricle. What do you think about that?
So maybe there's something that obstructing the fluid drainage.
Yeah. Whenever you have a fluid level in the lateral ventricle, it raises concern that that fluid is pus. And so the diagnosis that might be rendered here is ventriculitis. And so you're seeing, I think, what can happen when somebody has a meningeal problem. When somebody has a meningeal problem, that can extend into the parenchyma and cause an encephalitis, hence the term meningoencephalitis. When you have a meningeal problem, that can inflame the vessels, and you can get a secondary vasculitis. And when you have a meningeal problem, that meningeal problem can extend into the ventricles, causing a ventriculitis. So if we keep all compartments of the brain in mind, the parenchyma, the vessels, the ventricles, and the meninges, which are the four compartments, a primary meningeal process can transfer into the other three compartments, causing a compressive vasculitis, a ventriculitis, and an encephalitis. And so here I think that because there's fluid in the lateral ventricle, invoking the idea of ventriculitis, which is not something that a lumbar puncture can do, it's much more probable in this patient who has fever and neck stiffness that this patient has a meningitis. And I think his lumbar puncture is going to be very, very important. We didn't find any lesions to explain his vision loss or his hearing loss. which makes it likely that his vision and hearing loss is microscopic, probably from compression of the nerves as they exit the meninges. So that would be how we interpret the MRI. Any questions about any of that before we go back to that question of the bacteria and how you're thinking about them?
I'm just wondering, I'm not sure if it's the moment right now of doing that, but
Yeah.
I'm wondering if we could like broaden our DDX for something else, uh,
Mhm.
for an underlying condition causing the infection. For example, if we have a tumor that got infected and is causing the acute problem, or maybe something, yeah, mainly malignancy but we would have seen that in the brain MRI, right?
Exactly. The power of the brain MRI here is through the roof, in large part because it is telling us the problem is primarily meningeal. And that makes HSV encephalitis less likely. It makes enterovirus encephalitis less likely because both of them have primary parenchymal signatures in the brainstem or in the temporal lobe. So whenever you're thinking acute 2 days, meningitis, um, if it's just meningitis, then the viral causes are very likely enterovirus again, HSV2. But this is acute meningoencephalitis with a prominent brain involvement. And especially since there's pus in the lateral ventricle, I think that's very concerning to me for a bacterial infection. And so I think this is a bacterial meningitis until proven otherwise. And as you said, it's interesting that there's no systemic fingerprint of the disease. And that would make Neisseria less likely, but really important to think about. That would make strep pneumo less likely, but important to think about. Strep pneumo occurs at a much higher rate of invasive disease in patients with significant alcohol use. The same is true for listeria. And the curious thing about listeria is it tends to cause disproportionate CNS involvement compared to strep pneumo and to Neisseria meningitidis. So I would be really thinking about listeria in this patient, not because it's more likely, but because it would classically present as a brain predominant issue. But I think we think about these three organisms as base rate, but we have to remember that this person has exposures, and we have to think, could there be a zoonotic or exogenous form of meningitis? So these are questions that only people in these regions should really know, but it's worth practicing them. So if you were to think of um, maybe less common bacterial causes of meningitis that are associated with farm exposure or really anything that would cross your mind, I'm curious what would you come up with?
Thinking about that he's a rice farmer, I would think about fungi and also, and if I had to say one specific fungi, I would think in Aspergillus, but I'm not sure how much it is connected to rice farmer.
Yeah. The yeah, I think you're thinking Aspergillus in large part because of the environmental exposure, namely it's in the soil. Um, there is no simple way to like remember this stuff unless you have a lot of experience, but uh, uh, the acuity here is so restrictive to bacterial. Han actually presented a case of bacterial meningitis from an organism called Strep suis, which is a pig-associated infection found in Vietnam. It's the Streptococcus. The other really important infection to think about in Vietnam is melioidosis. It's called Vietnamese tuberculosis because it presents similar to TB in that it can cause all the complications that TB can cause. But in addition to causing tuberculosis-like presentations, it can present with a fulminant meningitis, encephalitis, sepsis, and skin disease. So I think here the LP is going to be very, very important. Base rate wins everywhere in the world, strep pneumo, Neisseria meningitis, listeria. But because of this person's unique environment, we're going to have to entertain additional infections. And the two things that I can think of are strep suis and Burkholderia pseudomallei, otherwise known as melioidosis. But I think practically speaking, LP, LP, LP. Cool? All right,
Yeah.
Han, tell us more.
Yes. My request is reviewed with lumbar puncture. He had done a lumbar puncture in the TB hospital and in the infectious hospital. The first in the TB hospital revealed the blue was cloudy. The white blood cell is 2,088 cells, with markedly elevated. The neutrophil is 80%. The protein is 2.7. The glucose CSF over the serum glucose is 2 over 8.9. The fungal is negative. The second lumbar puncture is in infectious hospital, which have the white blood cell is 7,004 cells. The neutrophil is 6,000 cells. The lymphocyte 700. The red blood cell is 9,000. The proteins is 1.85. The glucose SF over the serum glucose is 1.98 over the 4.44. The chloride is 114. We have a culture of the CSF which is negative and the microscopy is negative.
Yeah, Mariana, so thank you so much, Han. Very, very intriguing. What did you think of the CSF analysis? If you just focus on that alone, what does that do for you?
So, Rabih, I may need some help with the reference here.
Yeah. I think I'll tell you just to interpret it for you. The white blood cells in the CSF are very, very high, extremely high, I would say, and they're neutrophil predominant. That's the objective part. What does that make you think?
Bacterial.
Yeah, exactly. Yeah, exactly. I mean, bacterial until proven otherwise. So now, Mariana, we have a dilemma. Bacterial. But Han mentioned the gram stain is negative. What do we do?
Should we think about organisms that do not appear with the gram stain?
Yeah, I think so. Yeah, what would cross your mind?
Honestly, only chlamydia, but I don't think chlamydia would cause meningitis.
Yeah.
So, yeah.
Yeah, I think this is such a dilemma because the patient. The probability of bacterial meningitis is extremely high in a patient with hyperacute meningitis with such a marked pleocytosis. It's very, very high. So I think we would be very, very stubborn to not skip bacteria, even if the culture is negative. And I think that's what you did so well, is I was waiting for you to say, oh, it can't be bacteria because the culture is negative. But you didn't say that. You said, no, it is bacteria, and we have to think of what would be culture negative. And that's the key thing. So yeah, I think the culture is not perfect for anything. But there are some organisms that are especially prone to being culture negative. But the most important thing, Mariana, is if you were to guess why somebody would be culture negative, the most common reason is they got antibiotics. And so you can imagine this patient is at another hospital and so sick, he gets antibiotics and the cultures become negative. The cultures can be sterilized in the first 24 hours after receipt of treatment, but the cell counts are often positive. So it's not uncommon to get a patient who's transferred to your hospital for bacterial meningitis and they got antibiotics and their cell count is very positive, but their cultures are negative. It turns out that I think the culture negativity or the gram stain negativity of strep pneumo is about 20%. It's about 50% for Neisseria meningitidis and for Listeria. So if you were saying, oh, this is a true gram stain negative bacterial meningitis, you would probably lean towards Listeria and Neisseria. But when the cultures are negative, that makes all three of them a little bit less likely unless the patient got antibiotics. And so I think now we have to get a little bit complex in our thinking. Most of the time, Mariana, when I say TB, you think acute, subacute, or chronic. What do you think? If you hear TB, you think acute, subacute, or chronic?
Subacute.
Yeah, exactly. Have you ever heard or read about acute presentations of TB?
I'm not sure, but I don't think so. Unless it's like disseminated TB or this the second infection can be more acute than the first one.
Yeah, I think it's very humbling to learn more and more about tuberculosis. About over 90% of presentations with tuberculosis are subacute, but actually there are acute versions of tuberculosis, and there are even chronic versions over 2 years. Lupus vulgaris is an example of cutaneous tuberculosis that actually the patient has for years. Reza on RLR presented a case to me of acute tuberculosis pleuritis, 1 week of symptoms. Now, why am I bringing this point, Mariana? I'll ask you another question. When you think TB and you think CSF, do you think neutrophil or lymphocyte predominant?
Lymphocyte predominant.
Excellent. Exactly right. So most of the time you should think TB, subacute lymphocytic predominant. But what's really interesting about the rare cases that TB presents acutely is it tends to cause a neutrophilic pleocytosis, both in the CSF and in the pleura. In the case that Reza presented to me on RLR, the patient had a TB pleuritis, 1 week of symptoms, 1 week, very reliable historian, and neutrophil predominant pleural fluid. So here, Maya, simply, I think what you did is the most important thing. Be stubborn about this being a bacteria. The next key question is, did the patient get antibiotics before or not before this culture? And I think the organisms we have to think about that are true pyogenic bacteria are strep pneumo, Neisseria, Listeria, melioidosis, and strep suis. We have to think about them. But if the cultures are truly intrinsically negative, without us having made them negative, you then have to bring in a very common disease presenting in a very sneaky way. And the biggest learning that I'll impart to everybody is remember that TB can do anything. It usually does a subacute lymphocytic fluid disease. It can cause chronic disease, and in some instances can cause acute disease. So yeah, I would be entertaining that possibility, and of course, AFB cultures would be very helpful. But this is a very, very tricky case. I'm really excited to learn from Han, but wanted to see, Mariana, if you wanted to say anything else before we pass the mic to Han.
Yes. My last other quote is review the result. We have to a PCR in his CSF, and it's revealed that the activation of the Streptococcus suite, and the final diagnosis now is bacterial meningitis due to the Streptococcus suite. He has received dose of ceftriaxone, and he was recovered about his fever and his mental status for 1 week of antibiotic. But unfortunately, that his hearing function and vision function is temporarily lost until he was discharged from the hospital.
Wow, Han, such a humbling case and very, very scary diagnosis, but I'm glad he at least improved from obtundation to this. Wow, really, really incredible. Thank you so much, Han. Mariana, what are your thoughts?
Wow, thank you, Han, for bringing this case for us to discuss. Well, to be honest, I don't have a lot of knowledge in that. I'll have to read about that. And I think this is one of the most interesting things about VMRs, that we have the chance to see the things that we are not usually see in our books, and we have to read more and learn more. So thank you very much for this opportunity.
Yeah, Mariana, I think that, of course, this is a very rare diagnosis in the world, but it's probably not a rare diagnosis in Vietnam. And the truth is that this is, as you said, the value of being able to mix with people everywhere. But what really matters in this patient actually is just suspecting bacterial meningitis and treating. And the ceftriaxone that you gave this patient will easily treat strep suis. And then, what you did from the very beginning, you said fever, headache, and encephalopathy. I think encephalopathy is the problem. The problem's either in the parenchyma or the meninges. And then meninges, lumbar puncture, really, really high white count, neutrophil predominant, bacterial meningitis, and you are not accepting of the culture negative to dissuade you from that. And that's what you really should know. And then you get to learn something new about strep suis, which is it's very, very intriguing infection. I thought your thinking and reasoning was superb. Um, I didn't know that strep suis has a predominantly brain manifestation without systemic features. And I'm really excited to read more about that, because that's yet another really interesting clue, right? The patient has no problem anywhere else. And in retrospect, I think that's yet another clue to strep suis. Yeah, I thought you did it. You should look at the chat, by the way. You're getting a lot of love, but really, really excellent job done. Han, any learning points that you want to emphasize before we pass the mic to Julia for teaching points?
Yes, the Streptococcus is one of three Asian which is really popular in Vietnam about the bacterial meningitis. It can be sent with the to the pork farmer who do a job related to pig, and we usually careful examination of the skin of the patient to find a wound. Sometimes the wound is really small, and we can find in the clinical examination. In this patient, he didn't do any job related to pig or pork, and unfortunately we don't find any wound on her skin or any rest that suggest us to the Staphylococcus in this patient. And the first thing we think about this is tuberculosis meningitis, which is quite common in my country, and we have quite wrong that we transfer him to the TB, and which maybe delay her time to his treatment. Yeah.
I think Han, thank you for sharing that about the pig exposure. I had actually forgotten about that. Yeah, I think this easily could have been TB, very, very easily. So I think it's tough to make that decision in the moment. I think everybody tried their best, and these are very, very tricky cases to get right. So much so that you need a PCR to figure it out. And if you need a PCR to figure it out, it's probably not easy to know where the case is going. Alrighty, well, thank you so much for an incredible case, and a big high five to you, Mariana, for a really good discussion in a very tricky and acute sick patient with an epidemiology neither you nor I will have seen and may not see. Alrighty, mic to you, Julia, for the teaching points.
Thank you so much for this amazing case. I've learned so much, and I will try to summarize what I've learned and hope these takeaway points remind you also on what an amazing presentation that was. And what I loved most about it is that meningitis is a very common illness, but it can present in so many different ways, and how you approach the case taught me a lot. So I will start with our presenting symptoms like fever and headache. And Ravi reminded us that we can think about an inflammation inside the brain, but we should still consider the most common cause of headache, and that being just a symptom aside systemic extracranial inflammation or infection. So bear that in mind. In encephalopathy, so if we have a patient with fever and brain issues, we can distinguish three compartments. We can think about the parenchyma, the meningeal, and vascular causes, which vascular being the less common one. And when we have an MRI and focal lesions in a patient with a loss of consciousness, it's most commonly localized in the brainstem. That's important to know. Also, if we have diffuse cortical problem, for example, a meningoencephalitis, we often have central nerve affect, the central nerve affected. Yeah, the most common cause of vascular issues are multifocal embolic phenomena, like in an endocarditis and septic emboli, for example. When we have an infection of the brain, we usually think about viral and bacterial. In viral, the most common agents are herpes and enterovirus. And what we can think about, they often do not have manifestations outside the brain. But with bacterial causes, being strep, pneumo, meningococcus, they often present with a systemic fingerprint. But today we learn they do not have to. Also, we can think about TB and cryptococcus, and they often have a clinical presentation in between. Then we try to find a Venn diagram of vision loss and deafness. That the issue here is that we think of a central nervous issue in optical nerves, being a demyelinating process. And with cranial nerve, it's more an PNS issue. So if we try to combine these two, we end up on our differential list with PRES, pituitary hemorrhage, methanol intoxication, or also an aggressive meningitis that kind of compressing the adjacent nerves from outside. Then we saw on the MRI the thickening of the meninges, and then we have pretty much four causes. We can think about inflammation, CFS, hypertension, venous thrombosis, and also irritation. And that Ravi reminded us that is the reason why we if possible, we should perform a lumbar puncture after the MRI, so we avoid the secondary process. Also, we have the finding of fluid in the lateral ventricle, and that can be a sign for pus, and that being a sign for bacterial infection. Also, we can think about complications of meningeal involvement. So it can transfer to all three compartments. So vasculitis, ventriculitis, and also meningoencephalitis. Our patient had an alcohol use disorder. So two agents are very prominent there. So we can think about listeria and strep pneumo. And definitely we should think about listeria because it does have a disproportionate CNS involvement. Lastly, when in meningitis, we do need an LP and cultures. And what very important is that if we have culture negative finding, we cannot exclude bacterial causes, especially when we have a neutrophilic predominance in our LP. So in our patient, we still thought about listeria, neisseria, strep pneumo, and meidosis and strep suis because of his location. Lastly, we should think about the time course, and one thing I will never forget, TB can do anything. So generally we think about TB being subacute and with a lymphocytic predominance in the lumbar puncture, but we can also have a very acute presentation, and then we would even find neutrophilic predominance. Lastly, strep suis can present with a CNS predominance without systemic symptoms. So that was also something very new to me. Thank you so much for everybody. I'll have to think a lot about the teaching points, and very glad for the opportunity, and see you guys soon.
Oh, what a powerhouse. Han with an amazing case, Mariana with an amazing discussion, and Julia, those are superb teaching points. I love the way you organized them. It's like you heard the teaching points before they were made. It was really, really excellent job. Happy Thursday, everyone. So nice to see you all, and I hope you have a great rest of your day. Thank you.